you should have done the upper respiratory versus lower respiratory tract. All right. So if you have a sore throat, would that be an upper respiratory infection or a lower respiratory infection? Upper. Okay. What about pneumonia? Lower. Okay. Now, would upper respiratory tract have any components that are classified as a respiratory zone? We're talking about conducting zone and respiratory zone of the respiratory tract. Okay, what's the difference now? Upper respiratory tract are anatomically, differentiated only. Conducting zone versus respiratory zone is functional in description. So let me go back to this earlier slide. So here's the conducting zone structures and the respiratory zone structures. Okay. So respiratory zone, we're going to be talking about starting with the trachea, going through the tissues that are involved with each of these. To be a component of the respiratory zone, it has to be able to have gas exchange occur. So what type of epithelium provides a thin enough membrane for gas exchange? Simple squamous. All right, so we have to have at least a region of simple squamous epithelium available for gas exchange. And even though this says bronchial, as you'll see today, we start to see alveoli as part of the bronchial. It still has the epithelium and smooth muscle of a bronchial, but bleeding out, we have little sacs of simple squamous epithelium that provide gas exchange. Okay, so this is much deeper into the airway pathways where we talk about the respiratory zone. So upper respiratory tract and lower respiratory tract, trachea and downward, the trachea is part of our conducting zone. Okay. On Tuesday, we'll be talking about pulmonary ventilation, how we move air in and out. And we'll call the conducting zone, and I'll remind you, you don't have to write it down now, I'll remind you about it on Tuesday. We call the conducting zone the anatomical dead space. Why do you think we call it a dead space?
No gas exchange.
Same reason, exactly. No gas exchange. All right, so if I do very shallow breathing, I'm only moving air in and out of my mouth down to about this portion of my trachea. I could live just doing that, okay? Because I'm not getting any oxygen deep enough to where I have a simple squamous epithelium where it would be able to cross the membrane and get into my blood. So we'll be referring back to that aspect of it. Okay, so this is a functional division, separation by function, and upper and lower respiratory, a completely different set of structures separated by location. All right, so let's look at the cartilages of the larynx before we move into the muscles that are going to move these. I think this is about where Jeff finished on Tuesday. And why do we need the cartilage in our airways? Keep it open. Keep it open, all right, maintain patency. And yet we don't have the brittleness of a bone. So we have muscle attaching to the cartilage, all right, and associated with the cartilage, but we don't have the brittle components of bone tissue. Though you still can break your voice box. I had a former student whose son, she was an older student and her son was in his early 20s, and was skiing and ran into a tree branch at a speed sufficient to break his larynx. Okay. The first case of a laryngeal transplant occurred in a man from the southeast who liked to ride his ATVs on other people's property. And this one landowner got really tired of people breaking his no trespassing signs, and he strung a clothesline across their path between two trees, and of course they didn't see it. And he was the first one to run into it and completely destroyed his larynx. And he had to have it removed. And about 12, 15 years ago, he had a laryngeal transplant. And the type of inane questions that people ask reporters and stuff. And so he said one of the earlier questions he got was, well, does your mother recognize your voice? Does it still sound like the voice that you used to have? It's like, Why would it? I mean, it's a totally different structure and different muscles, and even when you're hoarse, your voice doesn't sound like your normal voice. But so it's flexible. I mean, you can squeeze it. Okay, feels a little weird, but it does have give and take that the cartilage provides to it. So when we look at the cartilage, I'm going to draw. How do we know on this view here which was anterior, which was posterior? Which would be the easiest way, or one of the easier ways to tell? Probably the quickest, without requiring too much studying, is the cricoid cartilage, remember, is whiter posteriorly than it is in the front. Okay? And the other is that we haven't talked about trachea yet, but the cartilaginous rings of the trachea are open in the back. So we have no cartilage along this surface, so that would also be the posterior aspect of it. Okay? So if we look at draw the cricoid cartilage here, and I want to add, actually I'm going to draw this a little larger because I want to add the muscle to it. So that would be cricoid. And then the thyroid is going to be we'll make this a dotted line since it's in the back. All right, and if we look at this posteriorly, we have two cute little cartilages sitting on top. And they kind of have that A-frame shape to them. So that helps me remember that they are the arytenoids. And then we have a pair of smaller ones. Why these are separate ones, I'm not sure, except that that's how they develop. They kind of form more like a hook. And these are the corniculate. Okay? I always remembered that because they look like little kernels of corn. So the corniculate ones. And then the hardest ones to see, we never have them in any of our models, come from the side of the thyroid up onto this long filament-like structure. And those would be the cuneiform. Okay, and then we have the thyroid in front of that. So the only way in which I would be able to ask you to identify a cuneiform cartilage is, this is our small larynx model, the one that came with the tongue, and you can see the lingual tonsil on it over there on the shelf. So we can't see, here's cricoid, we can't see arytenoid because it's covered by muscle here. This would be the corniculate. And see this bump right here? That's due to the cuneiform. That's the only evidence we have of it in any models. So I'd have to ask a question, identify the cartilage seen here deep to the mucosa, where it creates this evagination of the mucosa. All right? So the bump here is corniculate, the bump here is cuneiform. Now, we do have muscles associated with our cartilage and ligaments. So I'm going to put the hyoid bone up here. And there is a ligament between the hyoid and the thyroid cartilage, as you can see right here. So here's the hyoid bone, and here's the ligament connected to them. So muscles that pull the hyoid up when you swallow will pull the larynx up as well. All right, that helps to pull the epiglottis down. So we have thyrohyoid ligament. And then we have muscles that, between the various cartilages, that help to move the cartilages or move the vocal ligaments as we change the pitch or the amplitude of the voice. So the first one is between the cricoid cartilage and the thyroid cartilage. And this is the cricothyroid muscle. Its function is to tilt the thyroid forward. So when it contracts, we see the thyroid pulled that direction. So is that going to change amplitude or is that going to change pitch when we do that? You guys remember where your arytenoid, where your vocal ligaments are attached to? What two cartilages are the vocal ligaments attached to? Arytenoid to thyroid. All right, so if we're tilting the thyroid forward, we're stretching those vocal ligaments, and it's like tightening the strings on a guitar or a ukulele or a violin. The pitch goes higher, okay? So the function of the cricothyroid then is to increase pitch. It vibrates with a higher frequency. All right. When we look posteriorly, so that's a lateral view. And this would be a posterior view. There's a pair of muscles that have their origin from, and I don't test the origin insertion here, but have their origin on the cricoid and wrap around to insert onto the arytenoids. And they have two different names which have two different origins. So one name is posterior cricothyroid, which doesn't make any sense because they're not attached to the thyroid cartilage at all. And since we have already a cricothyroid muscle, if you forget and leave the posterior off, you're talking about an entirely different muscle and you get no credit whatsoever. So just learning it as posterior cricoarytenoid is a little easier. So it starts here and wraps around to attach to the lateral aspect of the arytenoid cartilage. Of course, we have two of them. So this is the posterior cricoarytenoid muscle, and it functions to spread apart. So you can play around with our larynx models, and it functions to rotate the arytenoid cartilages and spread apart the vocal ligaments. So it's going to allow more airflow to go through, and it abducts. Vocal ligaments. And then we have a set of muscles that do the opposite, that pull on the arytenoids and bring them closer, called the arytenoideus muscles, are just oblique and transverse arytenoids. So crisscrossing in this direction are the transverse arytenoids. And forming an X, superficial to them, are the obliques. And I'll show them to you on the larynx model. And these function to adduct. If we go back to this view here. Okay, here's the posterior cricoarytenoid, one of them. And transverse and oblique. It looks like the old-fashioned wooden doors or gates where that crisscross X kind of creates a support for the structure. muscle or skeletal muscle? Skeletal muscle. All right, speech is, unless you have certain neurological diseases, is a voluntary condition. And is innervated by the vagus nerve. All right. So if we look at, probably the best view right here. This is a diagram from Netter's. And I have a page open here to some of the constrictor muscles as well. And this yellow structure on here is the vagus nerve. Anybody remember the opening in the skull through which the vagus nerve passes? Which one?
Start with an N?
No, it starts with a J. Jugular. So, the glossopharyngeal, accessory, and the vagus nerve come out of the jugular foramen. And we know the vagus nerve primarily as a nerve containing parasympathetic motor fibers that are going to slow the heart down, increase the digestive activity. When we get to the lung, they constrict bronchioles, all right? But it also has motor function. So it's going to be involved with muscles for swallowing, the constrictor muscles. And it has sensory. It even has taste receptors in your mouth, along the sides of your mouth. So if you go to wine tasting and you kind of swirl the wine around your mouth, and you're going to get flavors other than just on your tongue. All right, it has pain receptors, so a sore throat, and a little piece of the eardrum are innervated by the vagus nerve. So sore throat, you can feel like you have an ear infection because the brain will project that pain back to your ear when there's nothing yet wrong with your ear. And in addition, your swallowing muscles are skeletal, and your laryngeal muscles are skeletal. So these are innervated by a branch of vagus. So vagus is going to come down, go down into the thoracic cavity in the stomach, but it's going to give off a branch that goes to the larynx, okay? And this branch is known as the superior laryngeal nerve. And then it has two branches, which are actually known as the internal laryngeal nerve branch of the superior laryngeal nerve, but you don't have to put all that down. Just internal laryngeal nerve is fine. So one branch is going to go pierce through the thyroid ligament, and the other branch comes down and innervates our cricothyroid muscle. So these two branches have separate functions. Internal laryngeal nerve is only sensory. And I'll write this on a chart on the board in just a sec. External laryngeal nerve is only motor. And you can see the muscle that it's motor to. So, can I erase this picture? Everybody's okay with that one? So internal laryngeal nerve is sensory to the lining of the larynx, above the vocal ligaments. Okay. And I'll show you on the model where I'm talking about here in just a moment. External laryngeal nerve is only motor to one muscle, and that's the cricothyroid muscle. Okay, so if we look at this image, this is the small larynx associated with that tongue. Here's our false vocal cords or vestibular ligament, and here's the true. The false one kind of hangs over and protects the true vocal cords. And so this whole area, the inside of the epiglottis and the laryngopharynx is going to have sensory innervation by the internal laryngeal nerve. All right, the external laryngeal nerve is going to be the vocal ligaments down into the trachea. And that's what I'm going to diagram now. The external laryngeal nerve is really called the recurrent laryngeal nerve. So why is it called the recurrent? Well, remember I said the vagus goes down into the thoracic cavity? Once it's down inside the thoracic cavity, it gives off a branch that comes back up the neck to the larynx. And this branch is known as the recurrent, meaning returning to, laryngeal nerve. There are two, one on the left side, one on the right. So on our model, this little yellow line right here, piercing the thyroid ligament, is the internal laryngeal nerve. All right. The external laryngeal nerve going to the cricothyroid muscle isn't seen here, but here's the recurrent coming back up. And on this model, you can see it as this white line. Okay, so it travels along the posterior aspect of the trachea. And recurrent combines both sensory and motor. Okay, so it's going to include both. So recurrent laryngeal is going to be sensory, so the region of the lining of the larynx below the vocal ligaments. And motor to all the other laryngeal muscles except cricothyroid. So, posterior cricoarytenoids. And vocalis, which I haven't put up here yet, I forgot vocalis, are all going to be innervated by the recurrent laryngeal nerve. Vocalis is the antagonist to the cricothyroid. So what does that mean? Apologize for going backwards here. So if the cricothyroid stretches out the vocal ligaments and raises the pitch, vocalis is going to pull the thyroid and pull the arytenoids and thyroid cartilages together, and that's going to decrease the tension and lower the pitch. Okay, so that muscle will be innervated by recurrent laryngeal nerve as well. Now, when I say that it drops down into the thoracic cavity and then returns, the right and the left recurrent laryngeal nerve have two different pathways that they follow. Selling models up here. So on the right side, get rid of anything that might fall off here. I've learned my limitations. So here's the subclavian artery and vein on the right side. And when the right recurrent laryngeal nerve drops down into the thoracic cavity, it curves back around under the subclavian artery and back up the neck. On the left side, it goes all the way down to the aortic arch and curves under the aortic arch before it returns back up to the left. All right, so that is clinically significant because individuals may develop aneurysms, an aortic aneurysm, and if that's a balloon-type aneurysm in the aortic arch, meaning it starts to stretch, it's going to stretch that nerve. And so you will have symptoms of hoarseness due to the stretching of the nerve and some of those fibers not innervating the muscles, when the actual problem, so a persistent hoarse throat, should always have ruled out as a cause an aortic aneurysm, even though the two are several inches apart, because of the fact that the recurrent laryngeal nerve is actually found in the thoracic cavity and then returns, as its name states, back up to the neck. Alrighty, so now let's move to the trachea, and we're going to look at the airways and compare them via their histology and the changes that we see. So the three things that we're going to look at for each segment of the airway are the identification of the epithelia that lines that particular component of the airway, the presence or absence of cartilage, and the presence or absence of smooth muscle. Okay? So either in lab, by seeing or not seeing those components, or by a verbal description, kind of like we did with the immune organs, has germinal centers, has smooth muscle in its capsule kind of thing, you could come up with whatever organ was being described. You should be able to identify the airway by the description of the epithelial cartilage and smooth muscle presence or absence. Okay? Can everybody switch on the board? Can I jump that? So until we get to any component of the airway that has simple squamous epithelium, our purpose is conducting, all right? It's to move the airway through, move the air through the airway, and along the way to remove as much dust or particulate matter as possible. So in the nasal cavity, that was done by the nasal hairs, all right, and some not sticky mucus, but fluid on the lining of the nasal mucosa. Large venous sinuses just deep to the epithelium of the nose also can warm the air. And there's some goblet cells secreting mucus that can also create a stickiness. And now we'll continue to see that with the presence of goblet cells in a large segment of our airway. So we're going to start with the trachea. The trachea begins with just inferior to the cricoid cartilage, and extends down to where it divides to form the primary bronchi. So if we look at a cross-section of the trachea, the lining epithelium is our typical respiratory epithelium, which is simple columnar, pseudostratified columnar with cilia. Cilia are present, goblet cells are present. The goblet cells secreting mucus that covers or coats the cilia. The cilia trap particulate matter, and the mucus traps the particulate matter, and the cilia sweep it unidirectionally up to your throat where you can swallow it. You swallow 1 to 2 quarts of this stuff a day. Okay, that goes. You also have cells that have microvilli, okay? But these are the primary characteristics of the pseudostratified columnar. Then to keep this airway open, there are individual rings of hyaline cartilage shaped as a C and open posteriorly. And this opening is closed by horizontal strands of smooth muscle. Given a name, we don't always name smooth muscle, but in this case it's given a name, trachealis. Now I have a problem with most of our models. They show this smooth muscle as traveling vertically although it's very easy to see in the slides that it's going in this direction and connecting those into the cartilage. So you see here the lines are shown going up and down when actually the muscle cells are oriented in this direction. Okay. Now in the next slide, the cross section of the trachea. There is zone associated with this organ. What's the organ posterior to the trachea?
Iris?
No, that's anterior to the heart and up lower trachea where it bifurcates. Esophagus. All right, so having this open C-shaped cartilage allows the esophagus, here it's collapsed. This is what our trachea would be like if we didn't have cartilage to maintain its patency. But this allows it to expand as you're swallowing food. So if you swallow one of those horse pills, or you don't chew your food and this big lump of bolus of food goes down, it would feel difficult to swallow if we had that hard cartilage there all the time. Okay. All right, let's go back and look at that image of the trachea. A tracheotomy or trachectomy is cutting an opening in the trachea. The tracheostomy is the opening itself. That's normally done right about here. Cartilage is 3, 4, and 5. A little rectangle or square is removed. This can be temporary. If someone's breathing muscles need to be rested, or someone needs to be put in a coma for a short or prolonged period of time, or it can be permanent. All right, if they have paralysis of those muscles or damage to the nerves, they innervate those muscles. Spinal cord damage above C3, that would need to be a permanent trach. Now, if someone is choking, all right, let's say that you're going through Costco with your daughter or your nephew, and they're supposed to ask permission to hand out food samples for kids. And let's say your back is turned and your daughter reaches over and grabs one, or somebody doesn't know the rules, or she's cute and goes ahead and offers her one, and she starts to eat it and chokes on it. Those little hot dogs are about the diameter of those small little airways. Normally choking occurs at the level of the vocal ligaments. Okay, spasm of the vocalis muscle can cause them to shut down. The first cadaver I ever dissected when I was in graduate school at UC Davis was working with the medical students, and the 4 of us had a cadaver that we were working on, and his cause of death was identified as being a heart attack. When we opened up his trachea, he had chicken and peas stuffed in his larynx. So I'll never know whether he was in the hospital for heart problems and had a heart attack and then choked, or started to choke and he died, and since he was there for heart problems, they just wrote it off as heart attack because he hasn't had an autopsy. But so normally when someone has an obstruction, it's in the area of their larynx and the vocal ligaments. So by going below that, you can bypass that obstruction. Now the problem with giving somebody an emergency tracheotomy and providing an airway, which you could do with a penknife or a sharp pencil or something, is we have the trachea the thyroid gland right across that area. Because it's endocrine, it's a rather bloody organ, okay? With veins and arteries and everything bringing in amino acids and carrying away the hormones. So if you try to cut through that on your own without being in the emergency room and the ability to cauterize it, you're just going to fill their trachea with blood. So the best site to provide an airway that's still inferior to the vocal ligaments is actually a cricothyroidectomy. So right here between the cricoid cartilage and the thyroid cartilage. If you take your finger, just slightly arch your neck, find your thyroid cartilage and just bring your finger down like this, it'll drop into a narrow gap, about 1/4 inch wide, okay? That's the space. It's a little bit larger than the spaces between the cartilaginous rings, and it doesn't have blood supply in that area. In addition, what other advantage is there to taking a sharp pencil and stabbing that area right there to get an airway than there is down here?
You don't go through the cartilage.
On the back, it's
Would that be above the Adam's apple or the
below.
below?
Below it. Because if you're above the Adam's apple, you're going to be above the vocal ligaments, and your blockage would probably still be present at the vocal ligaments. but the cricothyroid cartilage ligament is going to be below that. So here's Adam's apple, and we're talking about this space right here. Okay? So if we turn it around posteriorly and look, there's our large posterior surface of the cricocartilage. That's going to keep whatever sharp instrument you're using from piercing through the back, like it would down here, and going into the esophagus and causing further problems. Okay? So once you do that, now we have to maintain that opening. A pencil in there is not going to help the person breathe any better. So a plastic pen, a straw might collapse, and a pen that you can pull the ink cartridge out of would fit in there, and you could blow into that. Okay? Now, ambulances usually carry airways on there, on the ambulances, but the EMTs legally are prohibited from doing this particular activity. Paramedics may, but unless they've changed the law in the last couple of years, EMTs cannot do that. So if it was my kid that was turning purple, and the Heimlich wasn't working, I give it to me and I'll do it. Now, I've never had somebody write back to me and say, hey, I just saved a life doing this, but I always mention this in any class because that's a site that you can do without too much collateral damage. You would want to try the Heimlich when you were first, okay? That's using the air, not air, but the content, the pressure of the abdominal cavity by pushing in and up. You push a sharp, sudden movement of the diaphragm up. That decreases the volume of the thoracic cavity, and the intent is to cause an explosive force that pops, pushes air up into the larynx and pops whatever the obstruction is out. But if it's a thick, gooey, mucousy kind of a thing, that may not work, okay? Sometimes the choking is a spasm. There was a case, probably been about 12 years now, at the water park in Roseville, where the lifeguards saw the girl, I don't know if she was having a seizure or what. They called the ambulance, and they weren't able to intubate her because of spasms of her vocal muscles. And I've always wondered why did they, maybe they were EMTs and couldn't do it, but I've always wondered why they didn't do a cricothyroidectomy and go in inferior if they couldn't do an intubation and gain access through the vocal ligaments. Because all I heard was it was a spasm, they couldn't intubate her. I'm like, well, they could have always gone this way, but if they were EMTs, they wouldn't have had the legal right to do those. Yes.
So how far in?
Well, if you have a pencil or a sharp instrument that you're stabbing, you could just, even on a child, you don't want to try to get all the way to their vertebra, but you would want to make a force enough to go through, but that's going to be blocked by the cricoid cartilage. You don't have to worry about, really forceful, yeah, you'd probably get your pencil stuck in that cricoid cartilage. You don't have to worry about the softer tissue that would be posterior to the trachea. Okay? So I often, on a lab exam, will ask for a picture like this and put A, B, C, which is the best place to do an emergency airway, and you want to go between cricoid and thyroid cartilage.
Okay, so C it is.
Well, it depends. I might have C down here, so. I don't want you getting to Costco. I know she said C, but where is C? All right, so characteristic of a trachea by histology is a pseudostratified columnar epithelium, the presence of a single piece of cartilage, so sometimes the sections, it's not cut through all the way, you might see two pieces, but the C shape of the cartilage is clue, and our smooth muscle is limited to the open space between the ends of the C. All right? Now at the end of the trachea, at its distal end, when it splits into the two bronchi, there's a little ridge that's formed called the carina. And on Tuesday, we're doing our sheep pluck dissection. And it's a demo, so it's frozen. I'm not sure why, but it includes the liver as well. So it's right and left lungs, trachea, sometimes larynx, the heart, piece of the diaphragm, liver, and gallbladder. And so we need closed-toe shoes, and though it's wintertime, most of you are wearing closed-toe shoes anyway, and goggles, all right? And then if you wish, we've got dissection kits. I will be demonstrating, and you can help use an ambu bag to blow air into the lungs and see them expand and feel them. And if you wish, you can get the scalpels out and start cutting through and trying to follow the bronchi into the lungs. Okay, so that part's totally up to you. We started using the ambu bag because of a bad experience I had, which I said I was never, ever, ever going to do the sheep hook again. We have these long sterile glass tubes that we slide down the trachea, and it works unless the lungs have been lacerated in their removal. Slide it down as far as possible until they bifurcate, and then blow into them, and you'll see the lungs expand. And then they have a natural recoil. And so when you stop blowing, they recoil, and you have to take your, move your mouth away before you stop blowing. Yes.
Where this is going.
I got a mouthful of mucus and blood. And I was like, okay, that's in. Even if I wasn't a vegetarian, I would not be doing this again. And so now we add a piece of ventilating tubing and an ambu bag to do that procedure. At Sac State, they have air tanks associated, so instead of gas, which these aren't hooked up, we have air, they have air. And each group of 4 students gets its own plug, and the tubing is connected to this. Instead of pumping it up, you can actually turn the air on and see them expand that way. Actually, the force is so strong, you start breaking some of the membranes, you get little blebs of air pockets under the visceral flora. So that's what we'll be doing on Tuesday, and you can follow these. We'll feel the smooth muscle aspect and look at that to whatever level of interest you have. Now, as you can see on this diagram, the trachea divides, and this is dichotomous or trichotomous, 2 to 3 branches at a time. And the right bronchus has a larger diameter and is slightly more vertical in orientation than the left. So when structures like a kidney or a safety pin, hopefully closed, gets inhaled into the airway, most likely it ends up in the right bronchus. So that's where they would put a bronchoscope first to try to grab a hold of that because of that characteristic. Now the right bronchi characteristically look just like the trachea. So they would have the same C-shaped cartilage. They still have extensions of the trachealis into their components. But when we get to the secondary, even though some of the secondary may have some of those same characteristics, what we start to see, what I want you to understand is the characteristic arrangement for bronchi. All right, recognize, how would you know if I had a cross-section of a primary bronchus, and it was a primary bronchus rather, and not the trachea? What structure would we be missing? Nope, looks just like that. Size-wise, it'd be smaller, but there's something missing.
The smooth muscle?
No. What it travels with the trachea, but it's not going to split the esophagus. Okay? So now, it doesn't mean every trachea section has an esophagus, but if there is an esophagus there, you know it's not a primary bronchus. Okay? And if it's not, then it might be a primary bronchus for the trachea. So assuming that the primary bronchus is identical in appearance and arrangement to the trachea, we're going to switch to secondary bronchus. And smaller, okay? So let me put secondary in parentheses. And we're going to look at the characteristics of a bronchus, recognizing that it doesn't fit the primary, okay? So it's going to be secondary, tertiary, quaternary, smaller branches of the bronchi that have this. So its epithelium is going to be smaller in diameter, and its epithelium now, instead of being simple stratified, is just a basic simple columnar. Still cilia and still goblet cells. And probably more microvilli now. But these are still the more important characteristics. Cartilage is present, and it's what I call a discontinuous ring. Yes?
Sorry, you said simple colloidal or columnar?
I'm sorry, thank you for catching that. Columnar. Okay? So So the cartilage is present in what I describe as a discontinuous ring. So cartilage is all the way around, forms a ring of cartilage around the bronchus, but it's not a single piece. It looks like stepping stones. So still hyaline cartilage. And smooth muscle is present between the epithelium and the cartilage. And this time, the smooth muscle goes all the way around the airway as well. And it doesn't have a name, it's just smooth muscle. Okay, so except for the primary bronchus, bronchi have characteristically simple columnar epithelia, plates of cartilage, and a ring of smooth muscle. So here's the cartilage, okay? Here's another piece of cartilage over here. Here's the smooth muscle, seen here. Now it's been a while since some of you maybe have looked at cartilage, identified it. So if I show this on a lab quiz or a lab exam, I will always label the cartilage. I'll stick a little line on there and say cartilage. And then it's up to you to remember what type of airway has pieces of cartilage. Okay? So the tracheal cartilage I don't normally have to identify, but sometimes the plates of cartilage can be a little more difficult to see. All right, so on this model of the trachea and bronchi, there are little pieces that there's the different colors are showing the different levels of branching, but all of these are bronchi. Okay, they have cartilage plates all the way to the tips. Let's go back and look at the diagram. So here we have secondary bronchi. You can see the plates of cartilage, and even these smaller branches still have cartilage, so they're still going to be considered bronchi, all right? Now, there's a transition, so probably even some of the secondary bronchi would still have pseudostratified columnar, and some of our smaller bronchioles may still have, or larger bronchioles may still have simple columnar, all right? But I'm wanting you to know it as the characteristic arrangement, so most of them are going to have the appearance that I'm giving to you. So now, as we move deeper into the airways, we lose the cartilage. We have a shorter epithelium, so we switch to a cuboidal epithelium. And this is calling it respiratory epithelium, but for our purposes, respiratory epithelium is defined as pseudostratified columnar. That's respiratory epithelium. This is respiratory epithelium only because it's in an airway, right? When I say respiratory epithelium, I mean pseudostratified columnar. If you have a question, which of the following is characterized as respiratory epithelium? It's going to be the pseudostratified. So now, can I erase the trachea? And I will put up the bronchioles. So we've lost our cartilage. Obviously, our airway is going to be smaller in diameter, but still variable in size. Our epithelium is now cuboidal, but it has no goblet cells, because goblet cells are columnar.